works and in which psychiatric illness it works, and also we'll discuss some studies which will show the result why escitalopram has better efficacy compared to other SSRI. So escitalopram, the journey of 2 decades. FDA issued the approval of escitalopram for major depression in August 2002 and generalized anxiety disorder in December 2003. In European countries and Australia, it is approved for depression, anxiety disorder. In anxiety disorder, it covers generalized anxiety disorder, social anxiety disorder, OCD, panic disorder with or without agoraphobia. Some highlights on escitalopram. Escitalopram is highly selective serotonin reuptake inhibitor, has a low drug interaction, is highly effective in depression and anxiety, has a rapid onset of action, and there are very minimal side effects and requires no dose adjustment for renal dysfunction and older age. So generally the SSRI works by inhibiting SERT, that is serotonin reuptake transporter, and they act on the site and increase the serotonin level. But escitalopram has a unique variety. It also binds to the allosteric site, and by binding in the allosteric site, it enhances the binding to the primary site, resulting in more pronounced increase in extracellular serotonin levels. Clinical pharmacology, peak plasma concentration of escitalopram is 3 to 4 hours. Escitalopram and its dimethyl metabolites are weak or negligible inhibitor of human hepatic enzyme. The elimination half-life of escitalopram is about 30 hours. Dose of escitalopram in the lower end of dose range are recommended for patients with hepatic dysfunction. Does not impair cognitive or psychomotor function relative to baseline. Clinical evidence of escitalopram has been seen in depression, generalized anxiety disorder, social anxiety disorder, panic disorder, and OCDs. The role of escitalopram in depression. To see this role, we'll be discussing some studies that had been done. The first study is to see the efficacy of escitalopram in the treatment of major depressive disorder and compared with conventional selective serotonin reuptake inhibitor and venlafaxine. The other SSRIs that were studied were citalopram, fluoxetine, paroxetine, and sertraline. They studied when compared escitalopram in case of response and remission. They studied favor escitalopram. The result and conclusion of this study was that the total of 2,687 patients were included. Escitalopram was superior to all the comparator in overall treatment effect. In analysis by medication class, escitalopram was significantly superior to other SSRI and comparable to venlafaxine. In this meta-analysis, escitalopram showed significant superiority in efficacy compared with the active controls. In the next study, it was done between paroxetine and sertraline to see if their efficacy is equal or is escitalopram more superior to them. Based on analysis of 10 studies involving a total of 2,687 depressive patients up to 2004, escitalopram, when compared with all comparator including paroxetine and sertraline, was found to have significantly higher overall treatment effect, response rate, and remission rate. In a follow-up meta-analysis comparing escitalopram with active control, including SSRI and SNRI involving 4,549 patients in 16 RCTs, escitalopram was again found to be significantly more effective than comparator in overall treatment effect, response rate, and remission rate. Tolerability, a meta-analysis reviewing 117 randomized control trial involving a large participant that was approached to 25,928 and 12 newer generation antidepressant. Escitalopram and sertraline showed a superior profile of tolerability, with significantly fewer discontinuation of patients than other antidepressant, including paroxetine. Escitalopram and sertraline, in addition, a meta-analysis showed a considerably higher incidence of treatment emergent sexual dysfunction for sertraline than for escitalopram. In sertraline, there was 80% and escitalopram was 40%. Escitalopram has the highest cumulative probability in terms of acceptability in a recent review, escitalopram being the highest, 27.6%. In the next study, they show the comparative efficacy and accessibility of 21 antidepressant drug for the acute treatment of adult with major depressive disorder. This is the single largest meta-analysis in the world literature on the safety and efficacy of antidepressant medication in adults with non-psychotic, non-refractory, medically stable MDD, involving 522 trials of 21 antidepressant comparing 116,477 patients. All the antidepressants included in the meta-analysis were more efficacious than placebo in adults with MDD. Some antidepressants such as escitalopram, mirtazapine, paroxetine, agolomelatin and sertraline had relatively higher response and lower dropout rate than the other antidepressant. Escitalopram was ranked higher in both efficacy and accessibility compared to the all antidepressant, newer antidepressant. Thus venlafaxine, vilazodone, levomilnacipran and vortioxetine. So, in the head-and-head comparison of efficacy, operationalized as response rate, escitalopram, mirtazapine, amitriptyline, venlafaxine and paroxetine were the most associated with superiority over certain other antidepressants. Escitalopram and vortioxetine were most often associated with superiority over certain other antidepressants. In clinical practice that resemble antidepressant RCTs in study selection criteria, dosing, assessment, follow-up and other clinical action, escitalopram could be the best choice and reboxetine the worst choice. Escitalopram in depression with medical comorbidities. The effect of escitalopram in mental stress-induced myocardial ischemia. Firstly, I'd like to discuss about the mental stress-induced myocardial ischemia. When there is an emotional stress, there is a dysregulation in HPA axis leading to increase in the glucocorticoids, which cause the dysfunction of endothelials and causing atherosclerosis and finally myocardial infarction. So in this case, escitalopram has shown a significant help. Effect of escitalopram in MSI-MI. The REMIT study, a randomized double-blind placebo-controlled trial of patients with clinically stable coronary heart disease and laboratory diagnosed MSI-MI. Intervention eligible participants were randomized 1:1 to receive escitalopram or placebo over 6 weeks. Main outcome and measure. Occurrence of MSI-MI defined as development or worsening of regional wall motion abnormality, left ventricular ejection fraction reduction of 8% or more, and or horizontal or downsloping ST segment depression of 1 mm or more in 2 or more leads, lasting for 3 or more consecutive beats during 1 or more 3 mental stressor tasks. The result was found that of 127 participants randomized to receive escitalopram or placebo, it showed that escitalopram was more effective than placebo when given over 6 weeks. The significant decline of the mean HAM-D score was observed 3 weeks onward till the end of the study during escitalopram therapy. There was a corresponding decline in the mean fasting and post. This is the next study which they showed with the diabetes. In this, the escitalopram therapy showed there was a decrease in the glycemic rate. There was a corresponding decline in the mean fasting and postprandial plasma glucose level at 6 and 12 weeks respectively, and glycoside hemoglobin level at 12 weeks was observed. The role of SSRI is better in glycemic control. In conclusion, escitalopram is effective in treating depression in patients with diabetes mellitus and have beneficial effect on glycemic control. Escitalopram is efficacious as a dose of 10 mg per day for treating depression in most patients of diabetes mellitus, and a higher dose is required for response in more severe form of depression in diabetic. Escitalopram does not pose risk of weight gain and likely a weight neutral drug. The strategy to address inadequate response to initial dose. Escitalopram use pattern in India, a survey that was done among the psychiatrists, that is a knowledge, attitude and practice survey among Indian psychiatrists. This was a cross-sectional descriptive observational questionnaire based survey across India. Total 280 psychiatrists across India were surveyed and KAP, that is knowledge, attitude and practice, were evaluated. 12 questions were explored: indication, dosage, duration, efficacy, tolerability and comparison were asked and results were expressed as percentage. So the results were, in this survey, approximately 80% of psychiatrists reported escitalopram as preferred geriatric antidepressant. High preference to escitalopram could be due to its favorable pharmacokinetics, which allow co-prescription, and its tolerability profile. The preferred dose was 10 mg per day and duration was 6 to 12 months for majority of patients. Interestingly, 22% psychiatrists preferred the use of 20 mg per day. Conclusion out of this survey was that escitalopram recommended initial dose is 10 mg and maximum is 20 mg. In the current survey, no point of clinical utility of escitalopram. 76% of psychiatrists rated robust clinical utility and almost all psychiatrists has rated the utility as good to moderate. In Indian clinical practice, around 83% of doctors use 10 mg of escitalopram as a preferred dose regime. Almost all psychiatrists rated the tolerability and efficacy of as good to excellent in the treatment of depression compared to other SSRIs. In case of inadequate response to 10 mg of escitalopram as initial treatment for depression, what should be the next best step? Whether it should be dose optimization, switch to other drug, or combining other drug to escitalopram. To see what is the best, some studies were done. The first study that we'll be discussing is clinical practice guidelines for management of depression. Once an antidepressant medication has been selected, it can be started initially at a lower dose and careful monitoring. If at least some important more if there is some improvement, that is more than 25% is not observed following 4 weeks of pharmacotherapy, a reappraisal of the treatment regime can be conducted and a change in antidepressant may be considered. When patient shows 25 to 50% improvement during the initial 4 weeks of antidepressant trial, the dose must be optimized to maximum tolerable dose. If there is less than 50% improvement with 6 to 8 weeks of maximum tolerable dose and the medication compliance is good, a change in antidepressant may be considered. Guidelines recommendation, that is CANMET, Canadian Anxiety and Depression Treatment Therapy. There is only low quality evidence to support early switch at 2 to 4 weeks for non-improver to an initial antidepressant. There is substantial evidence that many patients receive subtherapeutical dose and or inadequate duration of treatment, and up to 20% may have poor adherence. CanMat recommends increasing the antidepressant dose for non-improvers at 2 to 4 weeks if the medication is tolerable and switching to other antidepressant if tolerability is poor. Now the role of escitalopram in generalized anxiety disorder. In this we'll be discussing 3 studies. The first about generalized anxiety disorder. It is a common disorder characterized by excessive, persistent and uncontrollable worry, nervousness or anxiety with attendant somatic symptoms that may include fatigue, irritability, tension, dry mouth, increased sweating and cognitive difficulty. GAD patient frequently present with secondary psychiatric disorder, mainly depression, and SSRI antidepressant are increasingly being considered as a first-line agent. Compounds in this class that have received an indication for generalized anxiety disorder includes venlafaxine, paroxetine, and escitalopram. So the first study was a short-term study, included a 252 patient in the intent to treat population. 124 were randomized to receive escitalopram and 128 to placebo. So escitalopram shows a significant better than placebo at week 4 and week 8 in reducing GAD symptom as assessed by the change in HAM-A total score from baseline to endpoint. The second study of Goodman in pooled data from 3 studies with similar design comprising 421 escitalopram treated patient and 419 placebo treated patient. A significantly greater decrease from the baseline in HAM-A total score for escitalopram was seen at week 1 and was maintained at every study visiting throughout the treatment period. And the third study, it was a escitalopram open label extension study. A total of 526 patients entered the study. Of this, 299 completed 24 weeks of treatment. Long-term escitalopram treatment led to continuing improvement in all anxiety and QOL scores. Mean HAM-A score at week 24 for study completers was 6.9 and 92% of all completers were responders. Clinical efficacy of escitalopram in generalized anxiety disorder demonstrated that escitalopram 10 mg per day was more efficacious than placebo from week 1 when assessed in HAM-A scale. Significant improvement in generalized anxiety disorder symptom were seen from week 1 onwards in patients treated with escitalopram compared with placebo. Long-term use of escitalopram, that is 24 weeks, for anxiety disorders were well tolerated and continue to improve the symptomatology and quality of life. Compared with paroxetine, significantly fewer patients with generalized anxiety disorder withdraw from the study due to adverse effect. Efficacy was similar in both treatment groups. Over the course of study, significant weight gain occurred more frequently in paroxetine treated patients than in escitalopram group. The role of escitalopram in social anxiety disorder. Social anxiety disorder is typically a long-term medical condition with an estimated 1-year prevalence of 1.1 to 4.4% and a lifetime prevalence of 12.1% with an onset of symptoms typically in adolescence. Escitalopram is effective in social anxiety disorder and along with it good tolerability suggests a favorable benefit-risk ratio. In this study, escitalopram was significantly superior to placebo when assessed using the mean change from baseline in the Leibovitz social anxiety scale total score to endpoint within 12 weeks. The total score of escitalopram were higher than the placebo. Avoidance and fear of anxiety was also improved by escitalopram when compared to placebo. The number of responders defined by CGI rating was very much or much improved, was significantly higher in escitalopram group, 54.2% than in placebo group, which was 38.6%. Escitalopram prevents relapse in patients suffering from SAD. The third study consisting of 12-week open label period with flexible escitalopram dose of 10 to 20 mg per day followed by 24-week randomized double-blind parallel group fixed dose relapse prevention period. Of the 517 patients starting open label treatment, 371 responded and qualified to be randomized to placebo or to escitalopram treatment for the following 24 weeks relapse prevention period. The time to relapse served as the primary efficacy variable and was significantly longer in escitalopram group than in placebo group. In conclusion, in this meta-analysis, all doses of escitalopram 5, 10 and 20 mg per day had significantly greater efficacy versus placebo as assessed by LSAS and CGI on the series of the endpoint comparison involving change in efficacy score from baseline and response rate. Given its favorable tolerability profile based on withdrawal due to adverse events, the results suggest that escitalopram has good benefit-risk ratio. Role of escitalopram in OCD. Clinical evidence. A randomized placebo-controlled paroxetine reference fixed dose 24-week study. A total of 466 adults with OCD was randomized to one of the 4 treatment groups for 24 weeks. The first group was 10 mg per day escitalopram. Second was escitalopram 20 mg per day. Third group paroxetine 40 mg per day and the fourth group was placebo. The primary efficacy endpoint was the mean change in Vibox scale, total score for baseline to week 12. Secondary efficacy endpoint included remission. The primary efficacy measured showing adjusted mean change in Vibox total score from baseline. The predefined primary efficacy showed a statistical significance greater improvement in Vibox total score at week 12 in 20 mg per day escitalopram group and in paroxetine group than in placebo group. On adjusted mean change from baseline in NIMH-OCS score compared with placebo, escitalopram 20 mg per day was significantly more effective for week 4. Escitalopram 10 mg per day was significantly more effective from week 12 and paroxetine 40 mg per day was significantly more effective for week 6. Escitalopram 20, in conclusion, the escitalopram 20 mg per day was associated with higher response and remission rate, improved functioning and better tolerability than reference drug. It should be considered as one of the first-line agent in the pharmacotherapy of OCD for longer-term treatment period. The summary of this will be the burden of MDD and anxiety disorder on healthcare resources and society is increasing. For MDD, escitalopram was superior to placebo and nearly equal to superior to other SSRI that were citalopram, paroxetine, fluoxetine and sertraline, and SNRI that was venlafaxine. Long-term administration of escitalopram has shown a preventive effect on MDD relapse and recurrence. Escitalopram also showed favorable tolerability and associated adverse events were generally mild and temporary. Efficacious and well tolerated across variety of anxiety disorder like social anxiety disorder, generalized anxiety disorder, panic disorder and OCD. In view of patient accessibility to acceptability of escitalopram based on both meta-analysis and pooled analysis, this drug was more favorable than other new antidepressants. Escitalopram is an effective and well-tolerated first-line option with balanced efficacy, safety and tolerability in the management of patients with major depression and various anxiety disorder. Thank you.